All right, we're going to go ahead and get started. Good morning, everyone. Welcome to today's Recovery Summit presentation, Bridge to Academia, Creating and Sustaining Successful Community Academic Partnerships to Improve Research and Clinical Outcomes. This webinar is part of a series hosted annually by St. Clair County Community Mental Health during the month of September, which is National Recovery Month. Today's session is being recorded and will be uploaded on the CMH YouTube channel for future reference. Please feel free to use the chat box for all questions or comments. Our presenters will be answering questions as time allows. Continuing education credits are offered for today's presentation. If you're requesting professional credits, you must remain on the webinar the entire time and complete the survey at the end of the presentation to receive credit. And now I'm going to turn it over to our presenters. Welcome, everyone.
Thank you, Christy. So my name is Ken Huvelman. Let me always jump in. All right. So some of our objectives today are just to work and help understand community engaged or community-based participatory research, learning the principles of it, identifying some of those steps on what it takes to establish a community academic partnership, and then also to understand some of the best practices, pitfalls, and things to bring when developing or creating a community academic collaboration. So my name is Ken Hubelman. I am the Substance Use Disorder Family Support Program Supervisor with Professional Counseling Center. I also am the founder of Ad Populum Consulting and Counseling. I am a member of the St. Clair County Health Department's Advisory Board. Locally, I work for or chair the longest acronym that I can think of, the St. Clair County Community Services Coordinating Body, Substance Use Prevention, Treatment, and Recovery Work Group, also known as the SCCCSCBSUPTR, because it's social work, it's behavioral health. We can't use real names. I also hold a master's degree in psychology and then a master's degree in clinical mental health counseling, and consider myself to be a person in long-term recovery from an opiate use disorder. We also have with us today.
Good morning. I'm Karen Campbell. Can you hear me? Thank you. My computer's telling me I'm still muted. I'm a clinical psychologist. I'm faculty research specialist at the Michigan State University in the Department of Public Health, which is housed in the College of Human Medicine. And the institute that I work in is called the Pediatric Public Health Institute. My training and background, as I said, is clinical community psychology, but I also have a background in public health and epidemiology. And most of the work that I do is in evaluation and research. The research subjects that I typically contribute to are anything that is from a prevention and early intervention perspective, rather than, as a psychologist, I'm, less focused on, individual treatment or family or group therapy, and looking at a broader scale, how can we get there before the problems get to the point where you need therapy? I also focus on maternal and child health issues and behavioral health issues in general, whether it's mental health like anxiety or depression, substance use disorders, social determinants of health, or inequities and disparities. And next we have Evelyn.
Hi, everybody. Thanks for the opportunity to be here. I'm an assistant professor at MSU in the Department of Public Health, as well as the Department of Translational Neuroscience. My research focus is it reminds me of one of Ken's acronyms. It's Community Engaged Dissemination and Implementation Science, which basically means I work to get all of the stuff, the information that researchers and practitioners do, into the hands of others who could make use of it. I also lead the Health Equity Report Card, or the HERC, for Flint and Genesee County, as well as a couple others that we're working on. Then next up is Emma.
Good morning. My name is Emma Chevalette. I'm a recent graduate of Michigan State's clinical MSW program. I first joined this team this past academic year as an MSW intern, where I completed my field placement, where I got to work in direct clinical provision, but I was specifically brought to this team as a research intern under the ACORN grant, which will be discussed more later on. And my work with the ACORN grant allowed me to work with other members of this team in additional research projects. This past summer, I worked as a pediatric public health initiative with Karen, and I was able to expand upon some of the research that I had started during my field placement in cleaning and writing syntax for Odyssey House's electronic health record system so that Flint and Saginaw Odyssey House's pregnant and postpartum programming can be assessed and evaluated, and the most effective interventions can then be implemented into the Port Huron office. I'm still currently a dual Masters of Public Health candidate. I'm set to graduate this upcoming May, and I'm once again working with Odyssey House in assessing clinical barriers to a full pregnant and postpartum population programming implementation.
So before we jump into this, I'd like to take a quick minute for a quick exercise. And I want you to think about, how do we perceive researchers? Really what I'm going to do is test your implicit bias, because why not? And if you can take a moment to either go to that webpage or scan that QR code. And we want to ask that question is, when you hear the word researcher, what's the first word or first few words that come to mind when you hear the word researcher? So I'll leave this screen up for a moment as we build the word cloud. So if you want to take that moment, again, just what do you think of when you hear that word? All right, and as we can see here, as they come in, we can see some of those responses for what is it that we think of? What is, again, implicit bias? And implicit bias is not always negative. It's a decision influencer. So what you can see when you guys hear that word researcher, we think science. I see boring, answers, out of touch, methodical. Some of the others we can see there, data or data. I don't know which version is correct, but we'll probably argue about that later. Someone's seen the atomic energy with Oppenheimer. Wonderful. And just looking at those, so you see these things that nowhere in this do we see community. Do we see partnership? Do we see, this part where it involves more than just the stereotypical lab or academic? We did this at the SUD conference last week and had some, nerd, just straight scientist. You almost think lab coat. Are some of the things that just come when you traditionally hear that term researcher. So what we want to look at is changing and shifting that and recognizing that there's this community-based participatory research really continuum that exists. This spectrum ranges from no community involvement all the way to that community participatory. And you see that community driven, community led, and it's this range of engagement or truly partnership, and how research is committed. So we have people that come in and do research. We have people come in and tell us what we need, or they'll look at your community, they'll look at your organization from above, and they'll make decisions or recommendations based on that. And maybe there's no community involvement. If you follow construction in MDOT and some of those, every now and then you have to kind of push back and say, hey, these are our neighborhood streets. You people feel like redesigning, restructuring. This is our community that you're about to place a bridge plaza in. We'd maybe like to have some voice in that. So it requires sometimes that may be community informed or community consultation. And you see this where the researcher or the organization comes in and takes a look and asks you what you think about it as a community. What are your thoughts? Would you like? What do you want us to do for you? Then you start to shift towards that community participation. This might be, we had 3 town halls. You folks were able to come in and talk to us, and we heard your opinions, and you wrote it on a board, and we served you lunch and cookies. And then we went back to our research and we did what we felt. Well, shifting towards that other part, it might be community initiated. This might be, hey, we have a landfill issue and we want you to come take a look. We see the problem, but research or academics or communities aren't hearing it. And we need someone to come in and look at this. So now it's the community is saying, we need someone else to come take a look. Well, that next step up towards this higher end of the spectrum is bringing in that community-based participatory. The people in the community aren't just at a couple work groups and then go home. Throughout the entire research process, they become a almost equal or equitable partner in that relationship. It is now your community-based organizations, your community leaders. It might be pulling some folks from the faith-based. It might be pulling city leaders, law enforcement, clinicians, but you're really bringing together this true multidisciplinary team. You're bringing things in outside of just, hey, here's what we think you need. We're going to do this for you. You're welcome. We're a university. We're a research firm. Congratulations, we did this for you. You should be thankful. It's looking at some of these things, and that shift on this spectrum, which is a creation from the MSU Academic Partnership. So this community-based participatory spectrum was actually created in a community-based participatory research group. So it's looking at this. Do we have equity? Do we have the same kind of power and control? Do we have the same ability for decision-making or influence? Whose benefit is this? Is this the researcher, or is this the community? Is this a little bit for both? Are the resources shared? So making sure that, as we move from the no community involvement, where there's really no equity for the community, towards that community-driven, community-led, we start to see some equal sharing. Then we want to look at those contextual factors. Obviously, is there trust? Everyone loves to hear this. There's a knock at the door and it says, hi, we're the government. We're here to help. Here's what we think you need. That's a good way to be told to leave my yard, politely or otherwise. So it's that part. Do we have trust? Is there a relationship or transparency? Why are you really coming in to take a look at our community? Why are you here, and what do you want for us? And why should we help, or why should we welcome you into our community? So the spectrum, it can range that way, where you're looking at, no involvement from the community, or maybe minimal. Again, maybe we took your opinion, or we listened to you talk for a little bit and said, those are great ideas, but you guys are just common folk, you're layperson, you don't know what your community needs. We've got this, all the way shifting towards that community-driven, community-led. Here's what we need. Here's what we want. We just need someone with the expertise or the skill set to help us get that for our community. So this range of how research can be conducted is something to recognize and pay attention to. And like I mentioned, you have that community informed. They're the advisor. Hey, we think we could use this. The community members may offer opinions, but we don't make the final decisions. That's community informed. They told you they were coming in to look at it. We're going to do an assessment. We're going to do a needs assessment, and we're going to see what you need, but we're not really going to involve you in the research gathering or looking for the things that you think we should. You told us you'd like us to look at this or that. Those are great opinions. I don't know. I have my own agenda. I have the things I need to do because it's my field as a researcher. That's great. I appreciate your input, but they're going to do what they want. That community-based participatory, again, partnering. You'll see this theme: partnering, relationships, respect, transparency will keep coming up throughout this. So partnering with the people who are actually impacted by a particular issue. If we're going to look at disparities, then we need to talk to the people who live in areas that may not have the same level of resources. We have to look at those folks and ask them what they see, what they hear, what they think they need. And then with that community base, you're also looking at research to equip communities. You did an assessment for the area, and then you left that area with something that they can use going forward. They have the materials to take what you did and use that for their benefit. It's the opposite of what we call helicopter research. That is where the research team will come in, they will take a look, they will say, here you go, we published a cool thing for you, and then they take off and go on to the next community to do research. It's almost this, hey, we brought you this and then we left, and you don't even know what they brought and you didn't ask for it. It would be almost if DoorDash showed up at your home. Thanks, I appreciate the food that I didn't know I needed, and now they're gone, so I don't even know who to talk to about why I have this thing. So that helicopter is that in and out process. And then in that community-based research, you want that community left with what they need. The community is asking for something. The community knows it needs something. And you need to be able to come out from that with what the community needs, not necessarily what the researcher needs or the university or whoever's bringing that in. So those are some of those basics and understandings of that spectrum of community-based research. No involvement to either community-led or a community partnership. And what we did is some of the ways that we came together. So explaining sort of some of the different things that our group, our collaborative has taken part in, some of the things that we've done to implement some of this community-based participatory research. So a large portion of that started with Flint, Michigan. Just down the road from us here in St. Clair County, there was this thing called the Flint water crisis. Flint Odyssey House operated a residential treatment facility, and they had a residential treatment facility that had no water that you could drink from the faucet. So you've got 100 plus people, 40, 50 staff in a building with no access to water, trying to operate, trying to maintain a normal level of operations, and you can't because of this water crisis. And it took about 2 years after that crisis for a true state of emergency to be declared. And what that triggered is a lot of eyes on the city of Flint. A lot of people started to look, and a lot of those people that started to look were researchers. The outside community came in to, I don't want to say save, but they knew that they could come in and help, and they're going to look at all the things and see what's going on. And it just became this area of intense research, intense folks there. And what we looked at was we needed to have the community voice in that, the faith-based community, the treatment facilities, the people who lived in Flint knew what they needed. They didn't have the resources to look into it. They didn't have the resources to do the testing. They didn't have those things, but they knew what they needed, and they knew they needed to be at the table. It's the old phrase, nothing for us without us. They needed to be part of. So Flint Odyssey House joined with Michigan State University College of Human Medicine and the Department of Public Health to create the Flint Center for Health Equity Solutions. This was that collaborative. This was that community participatory research. They started to sit and talk and have these conversations continually with partners from all over. That was more so in that direction. Michigan State University, they were the holders of the money, and they brought in these groups and created research that way. Then it went the other way. Flint Odyssey House received a SAMHSA grant, and they had the money. So all of a sudden, you have a treatment organization that has the money, that needs the evaluator, that needs the university. So that power dynamic, that shift happens. Hey, I have what you need. You have what I need. We need you to come in and work together. So that SAMHSA grant was to evaluate some of the, what they called off-the-shelf project. Then you had that whole thing that happened in 2020. Some of you may remember it. It was called COVID. There was a slight pandemic that happened maybe for, a few months there. And then in a subsequent economic crisis. And again, we started to see more issues happening from that. We saw treatment stays shortening. We saw different anxieties and different concerns with people coming in. So what happened in Genesee County and Flint was, I don't want to call it a perfect storm, because then it sounds like we're glad that we had this, but none of these were wonderful things. But it brought the attention there, and it was, hey, academics, you can't come in and tell us what to do. We're a community here, and we have knowledge, we have resources, and we know what we need also. So because of these number of things, you started to see some of that community partnership and community-based research. And then what that rolled into is this strengthening Flint families. Emma, you can tell us a little more on this one.
Yeah, so as Ken just introduced, this first example of community academic partnership was through the implementation of Strengthening Flint Families, funded by FCHES, the Flint Center for Health Equity Solutions. And FCHES assembled this multidisciplinary team of public health researchers, policymakers, health officials, community organizations, and faith-based institutions to implement evidence-based and promising practices within the Flint community in order to prevent chronic disease and promote health equity holistically. Strengthening Flint Families expanded upon the Strengthening Families program, and it served as a behavioral health initiative aiming to reduce behavioral health inequity and promote family resilience by building upon support systems at the individual, the familial, and the community levels. So this all worked by Flint Odyssey House prevention staff collecting, storing, and de-identifying their client data, their clinical outcomes, and sharing their data with their academic partners. Contrary to common research practice, though, it was Odyssey House who chose the evaluation measures, the fidelity assessments, the outcome assessments that were meaningful to them as a community institution and were empowering and beneficial to the clients that they serve and the outcomes that they need. This is in contrast to what's typically done, where the academic partner, the researcher, comes in and dictates what they want to see measured, and by what means. Moving on to this next slide. This next example was through Flint and Saginaw Odyssey House's Enhanced Parenting Project for Pregnant and Postpartum Women, funded by SAMHSA. And this expanded upon comprehensive treatment, prevention, and recovery support services for parents with children in residential substance use treatment, by ensuring that post-discharge clients had community-based services to rely back on. So this necessitated a holistic approach to pregnant and postpartum needs by combining individualized treatments with the inclusion of the client's partner, co-parent, parallel parent, and other identified support persons who are not enrolled in substance use treatment, but who the client deemed as necessary to their recovery pathway, their recovery success, and the achievement of their clinical goals. Odyssey House implements a participant to provider model so that the peer recovery coaches and parent advocates employed at Odyssey were once former recipients of substance use treatment themselves, have graduated programming, and are now in long-term recovery. So these peer recovery coaches and parent advocates were once again the people who were collecting, storing, and de-identifying their data, their client outcomes, and sharing that data with the academic partner. An inherent benefit of the community serving as researchers is that the peer recovery coaches and parent advocates shared a lived experience with their clients. They shared that experience of recovery and recovery while parenting, which inherently supported quality and accurate data because that data was collected hinged upon the therapeutic alliance, central to which should always be trust and respect. So then once shared, academic partners were then able to take that data, which was longitudinal in nature. It was collected over a 5-year funding mechanism. And this longitudinal data increased the value of the metrics that were being assessed, because when the metrics are assessed over time, they become meaningful and they become contextualized within a community so that the academic partners can assess and evaluate and then disseminate in a way that's mutually beneficial to both partners.
And then what we were able to get out of that was this presentation. So this was presented at the Healthy Flint Research Coordinating Center Research Symposium in 2022. What we were able to do is take this entire evaluation, this entire look, and create something useful. As a clinician, as a clinical supervisor, as a person who has been told if you didn't document it, it didn't happen. And what we recognized and came from this is we realized that Flint Odyssey House as a service provider had truly a treasure trove of data points and in data. It existed. It was just known as documentation. It was the stuff we put in because the person above us told us to, because CARF told them to, and the LARA told them to. So it was this whole fun part. It was documentation. Why do I check the box that they're pregnant? Why do I check the box that they're a veteran? Or why do I care how long they've been using? And all of these things, why do I care as a clinician or a peer recovery coach? I'm trying to get from one appointment to the next. What we realized is we knew we had this, but we needed that other viewpoint or other set of eyes. When you bring in a Corinne or a Heatherland or an academic researcher and they start to look and they go, oh my gosh, look at all of the things that you hold. Like, I can't speak for them, but that's probably the kid in the candy store that goes, I don't even know where to start because you have demographics, you have outcomes, you have, holy cow, it's here. We're clinicians, we're providers. We don't see it that way. We see it as tasks. We see it as extra stuff that we don't really want to do, but we have to because there's some sort of measure that says we didn't get it in on time. But then you can use this to help your clinicians, to help your staff that is entering the information understand the why. All of that is necessary. If you put it in the right hands, if you change the way you look at it, you develop outcomes. You develop a model. You develop something that says evidence-based practice. You take all of the work you've done, and maybe you've got those clinicians that see it. We do this thing and it's pointless, or we do this thing and every time I do it, man, does the group love it and they want it. Well, you put it into an evaluation, you do that true research on it, and you start to see that things work. You start to see what's effective, and then you start to see what isn't effective. So what we're able to see with some of these things is we need to follow up soon after discharge. Standard requirements are every 3 months and 6 months follow-ups. Well, guess what the person did 24 hours after they left? They went back to the home where they left to come to your treatment facility. You might want to check in with them in the first week to see how they're doing. Did you follow up before their intake appointment for their outpatient care? Did you address some of these other issues, such as, alienating policies or things that you hadn't looked at because you didn't know it mattered? Oh, this population needs it done that way, but we've always done it this way. So starting to recognize those things, and it came from this knowledge base that was already existing. It already was there in the EHR, in the documentation, but we had to bring out that partnership to truly see what was there to get best practices. What are we doing that works? What are we doing that doesn't? And then again, it becomes that selling point. If I can sell to my clinicians or my other staff why they have to document, now they might want to. It might not be 2-3 weeks behind. It might almost be in that 72-hour window that we're supposed to, kind of hit. So it became this change in conversation, became this change in buy-in for the Odyssey House organization. Now I get why you want me to do documentation. Now I see where it goes. It has value beyond X's and O's, checkboxes and serial buttons or radio buttons and all the other stuff that you just made me click because I thought you didn't like me. No, this is data that is useful. And it took the academic side and that other side to come out and kind of explain that. You don't see that from within. What led to the next shift was a small grant from Michigan State University's Addiction Consortium on Research and Education Network, or ACORN. You just ignore the E and then you get the actual, shuffle some letters and then you can make a backronym however you like. So ACORN offered our group $10,000 to create a landscape analysis in a substance use disorder health equity report card. I'm pretty sure that everybody attended our amazing presentation on the 12th already this month. So you guys are all experts in this. But what this kind of stemmed from was myself, community member, as that chair for the substance use prevention treatment recovery work group, as a clinician, as a person who likes looking at numbers but doesn't fully always understand them. We were scored positively by the state of Michigan's substance use vulnerability index. They said, you guys have all the treatment. You guys are in the top, I think, third for counties with treatment. You guys have the treatment. You guys are doing great. As a provider, I said, but where? But what? I didn't agree with that. And I can complain, I can shoot an email, I can try to be engaged in that, but I don't have the credentials. I don't have the MPH. I don't have the PhD. I don't have the true knowledge to understand what was going on. So that allowed for this partnership where I said, here's the thing I see. How do we move and take a picture of it? And then I was able to join this kind of collaborative and work with Corinne and Heatherland, who paid attention in those statistics classes, who remember Cohen's effect sizes and some of these other things that I remember. I passed the class and it went right out the ear because I don't do evaluation. I don't do statistics, but I was in some of these and I was like, oh yes, like I remember all of this, kind of. And it was actually kind of nice. It was energizing as that community partner, as that clinician, to take some of those courses we were kind of required to take in graduate schools and see it go into effect and be part of that thing, to move from here's what I see to here's how I almost prove how what I see is actually real or a thing. So we looked at services available in St. Clair County. What do we have? Where's it located? What kind of setting is it? Do I have to go to jail to get treatment? Do I have to go to the hospital to get treatment? Where do I go to get care for a substance use disorder. So specific location, specific population, very specific services, and just, do I have access? So we were able to take that and map. And as we found, obviously, there are some issues with those, and we may have a lot of outpatient services, but not higher levels of care, such as withdrawal management, residential, or opioid treatment programs. And then we paired that with Heatherland's expertise in this health equity report card. Everyone gets a report card. Some of us get a report card that we bring right home and it goes on the fridge. Other of us get a report card that might get lost in the mail for a week or two. It's technically at the bottom of our backpack. We didn't really want to go home with it. But we recognize that this model of rating or scoring a community based on some health equity is very translatable. People understand it. They know an A is good. They know an F is not so good. So it really made it digestible for both an academic side and the community side. So it has, again, dual mutual benefit for both parties. And we were able to look at some of those and create some health indicators, recognize some health disparities across our county. Some of these things were obvious, that people in Port Huron are more likely to not have access to a vehicle. So then it paired with our landscape analysis, good, because we have services for the Port Huron community that they can get to without a vehicle. But then we had other things that said, uh-oh, not so good. It's only in Port Huron is the majority of our services, with a couple outlying clinics for the other folk. But then when we paired that with another part, is that the individuals who live in St. Clair County outside of the city of Port Huron are 4.5 times more likely to die of a fatal overdose. And you started to say, well, maybe we need something in between the two. So you were able to take this map and landscape analysis of where treatment was, and compare that with some health inequities to start to see, are we doing all right? Is what we have working? And, the goal of this was really to inform prevention intervention, to help identify, what gaps exist, what it makes sense to fill those gaps. And that's when I kind of joined this team. That's when we pulled myself from, the Flint community had been involved, and then that brought in some of this Port Huron, St. Clair County. And we started to take this deeper look and realize that, hey, maybe we can do something. And then that led to the most recent, which Corinne can explain.
Yes, this current or next project was actually happening in the background of ACORN, because we usually have several things going on at the same time. And this program evaluation and Port Huron implementation, which we call PEPI, and its sister grant, the Dissemination and Implementation Science Grant, is a two-part grant that's a direct follow-up of the funding that we have from SAMHSA, doing the Enhanced Women's Services or Enhanced Parenting Program for pregnant and postpartum women. So the PEPI DISC grant is geared towards following up on the piece where we need to figure out some things of why things kind of don't operate the way that they used to since COVID hit, and how can Flint Odyssey House best serve their pregnant and postpartum women who are receiving substance use services in a way that enhances their parental supports to reduce ACEs in children, which includes supporting their parallel parents or co-parents, which could be fathers, grandparents, whoever the pregnant person or postpartum person identifies as their co-parent. So we received funding from Blue Cross Blue Shield Michigan, which just started last December. We're coming up on our first year. It's a 2-year project. And we need to answer 2 major problems. Since the COVID pandemic hit, we noticed during the SAMHSA grant that the treatment compliance rates for residential or inpatient treatment plummeted. It went from an average of 90 days to an average of 15 days. And at the same time, they were surprised to find out that the services that they always have been providing in the community to pregnant and postpartum women after they discharge from residential treatment, they get about a year of follow-up afterwards, that the responses to those services in the community were much stronger and much more effective than they normally were. So we want to figure out the answers to those 2 questions. And we're doing that by doing a program evaluation in the first year, which is the current year that we're in. We're looking at all of the data, whether it's medical data, child data, family data, all of the data that we have access to in the electronic health record, and surveys from that the peer recovery coaches or parent advocates do in the course of different programming, and look at it all together, any required reporting that SAMHSA had us do, and to see if we can see any patterns that could help explain the answers to those two questions. And that's involving a lot of, I was going to say data cleaning, but before we could even get to the data cleaning, we had to find the data. Because as Ken pointed out, and as most of you know, a lot of the data that you collect is for a specific purpose that usually has nothing to do with research. And when you're wanting to research and analyze data, the data has to be collected and entered in a specific way for it to be useful. So we're backtracking and trying to get the data identified and entered into a central database so that we can clean it and analyze it so that we can answer some of those questions. Because the goal is that after the end of this first year, sometime around December, we would like to have those findings to see if we can identify best practices to increase, if there's anything that we can do to raise the residential treatment compliance rates back up, but also identify which components of what they're doing that can be community are most effective. And the reason for that is the dissemination and implementation piece, because Ken, who is in Port Huron, whereas the data from the SAMHSA PPW grant was done in Flint and Saginaw, where they have both residential or inpatient and outpatient services. They don't have residential in Port Huron. As Ken mentioned with the landscape analysis, there's a lot of gaps in services. It's a rural community, it's underserved and under-resourced, and we want to be able to take the best of what's happening in Flint and Saginaw, since they're having so much success with those outpatient services, and identify those key components and implement them in Port Huron so that it's more cost effective, because they don't have a lot of resources to do all of the programming that are done in the other two counties. So we want to do the best of the best with evidence-based information. So yeah, I think that's all I have to say about that. We'll go on to the next slide. I don't want to take up too much time.
And I love the way you guys politely call it like syntax and data cleaning and use your researcher words. I think that's the polite phrase I can say. And it is that. It's the mess that is documentation from clinicians, peer recovery coaches, peer support specialists, and case managers who just need to get to the next case. Did I have to put the whole word yes, or could I put the letter Y? And to most people, that's no big deal. If you hand those two, yes and Y, to Emma or Corinne or Heatherlyn or a evaluator, those aren't the same thing. And so I love your guys' phrasing of like cleaning versus pulling your hair out and going, what the hell did these people do when they put in documentation? And sometimes it was simple. It was one I learned after I joined this group is if you check a box that a woman was pregnant when she entered treatment, male, or maybe just my logic said when she has or delivers the child, I uncheck the pregnant box because they're no longer pregnant. Well, I didn't know that that removed them from every thread of data that was prior, so they never knew the person was pregnant. And it was simple things like that that as a clinician, you don't see. And that's that part, like the community partners that we see here. So our team that we have is myself and Kristen Young, who's a director of prevention services at Glen Odyssey House. We have that part, like we have our viewpoint, we have our mindset, we have the way we look at it. Can be community-based, community-driven, both have histories as clinicians and direct service providers. So we have that viewpoint from ours with our own perspectives. Then we brought in Emma Chevalette and then Blair, am I missing Blair's last? Warren. Both who are kind of that students, trainees who are transitioning from academic to, I hate to say real world, because the academic internship, that's absolutely real world, but since it's for free and it doesn't really count as work, somehow it's not the same. And then moving to our academic partners with Heatherlyn, Corinne, and then Amy Drahota, who's also with Michigan State. So we created this, shared collaborative that led to this blend that really works. You need some, again, I look at the Ken and Kristen side, I was going to say some loud people who can kind of come in, and we've seen the issues. We just don't know how to phrase it right or how to shift it to make someone else understand it. So taking that look, like now we kind of understand what is this community-based stuff. We have a real life example. Hey, look, this group put it together. So all we need to do is get a couple folks with PhDs and a couple providers and go grab us one of those interns and we can do this ourselves. Kind of. But there are some barriers to partnership. Imagine that. There can be some rocky parts of the relationship. And some of those barriers from that community side is understanding that we need to communicate with the researchers when things just don't or won't work. I love that you want me to do this assessment with someone who's in the emergency department, but it has 75 questions and they can't stay awake. They just had a tube removed from their throat because they overdosed 45 minutes ago. They're never going to complete all of these things. Can I ask less questions? So being that voice of what's going to work when I have to go to a client or in a group and provide it and say, this isn't going to work. This is what we need to change. And I have to have that as that community provider to go, that's a great idea. And it might work on paper, but in the real world, not so much. Another barrier is understanding that research is kind of slow. We have a crisis, we have issues, we have needs. The clients that are struggling are in my office right now. Great. And if you roll back to that Blue Cross Blue Shield evaluation grant and the time frame, that's a 2 to 3 year time frame. Yes, but I have people in my office that are currently pregnant right now that need to know whether what I'm doing is working or not. That push from our side and to really understand that research doesn't move at the speed that we want it to. In the community, we have to learn to slow down and understand that. So that's another barrier. Our timelines are different. Also, from that community perspective, we need to understand that building something that can't work, following the funding, we need to know that we need something that we can afford. That is a great tool. It only requires a server and 3 people to keep it running and 6 staff to work in the background. Cool. That worked really well with grant funding, but now what? You've taken your academics, you've taken those wonderful interns, you've gone. What are we going to do with this? And if it doesn't have the funding to keep a program going or see it, it goes on a shelf and no one does it again. And it was a waste of everyone's time. Then we have that other part is dissemination approaches need to meet our community needs. What did you create and do I have access to it? Is it in something called SharePoint, which is going to need me to log in and reset my password every 6 weeks? Because that's not fun. Where is it? Is it usable? Is this something the community has access to? And maybe not just the target or sorry, the focus group, the people that were initially using it, but maybe we want to bring in another organization that also can benefit that. Or, hey, it worked for this group. Can it also work for this group? Or can we share this across communities? Do we have access to the findings and co-created tools? This is that other fun part. I'm going to pick on Heatherlyn and Corinne again, because that's what I do. Usually I wait till Friday mornings when we meet over coffee. But they read like articles from peer-reviewed research journals that are super bland. Like the only picture in there is a chart, and some of those charts don't make sense. They're the kind of people that when they read it, they don't just read the abstract and the discussion results section. They look at the methods and the results and like all those Latin numbers and stuff. That's super helpful for them. They understand that that's useful. But if that's what I do and I go, hey, we just published this in translational neuroscience, here's your thing, community. No one knows what that is. Is this something that can be disseminated easily? Is it a work group? Is it a presentation? Is it news media? What do we have that works for both sides? So we have to have that understanding in conversation that from the community perspective, these are some things we have to understand and know that we need. From the research perspective, they have their own barriers to partnership.
Yes, and I know one thing from the community's perspective that Kristen complains about often on behalf of Flint Odyssey House, because we work on a lot of grants and presentations and things together. Community partners just have a hard time getting access to those research journals and publications. And if they did want to look them up and read them, a lot of times they have to come to us and we have to use our university privileges to get them copies of the PDFs of the actual articles. But some barriers from the research perspective. the balancing what we always have done with the needs of the community partner. That can be really challenging. It's something you always have to keep in mind, because you have to remember that you're not working with community to get your needs met as a researcher, right? You have to prioritize what is best for the partner and the people that they serve, because that is the reason for what you're doing, full stop. And Ken alluded to before how excited researchers get about having access to data. The kid in the candy store, that's not to be dismissed or diminished, because it's really difficult to get access to high quality data. And it's even more difficult to get access to data from real world people outside of a controlled clinical trial in a lab setting, where you set up all your variables and everybody looks at it, has all the demographics the way that you want it, just people as they are, as they come through the door. That's really a wealth, rich information. So I think that that's a good trade-off, to get access to that kind of data. If you can get it collected systematically and at a high fidelity, high quality, to put the community partners' needs first in terms of what works for them. Is it too many surveys, survey fatigue? Your clients just have, are always filling out forms and they're over it and they're giving, quick nonsense answers because it's just, too many forms. Just whatever it is that the partner comes to you with, you have to find a way to make it work for them. I prioritize their needs over mine first, always, because without them, I don't get the research done. To get published, to get funded, and to get to do the product, I look at that and I think of my annual evaluation for my job. It's like there are certain things that you have to get done as a researcher, as faculty especially, and getting publications out, pulling in grant money, and overseeing high-level research and things like that. It's just a pressure to always do those things. And sometimes you just want to work with the partner and work with the community and see that what, they're getting their needs met, but you also have to be realistic and do your job and meet the demands of your job. As for the speed of research, that's the same thing Ken mentioned. It works both ways on both sides. Takes a long time. It's a lot of work. It's a lot of effort. Sometimes you have to submit a grant application several times before it gets funded. When you are working on research, the process of the data collection, the data entry, and the data cleaning is very systematic and formulaic and rigid. It has to be to get good quality data, but it's very time consuming. We have like a presentation that we did recently where we haven't been able to present all of the data yet because all of the people that we need to fill out the survey haven't responded to it yet. So we're still trying to do that so we can have a final product. Research restrictions, we have to adhere to the ethical guidelines of research practice, which is a good thing. I'm not complaining about it, but it means that you have to be aware of those things and make sure that nothing that you're doing is violating those policies. And sometimes you just have to modify what you're doing in your research based on what's happening in the real world. And that sometimes has an impact on the analyses that you had planned to do or promised to do, or how you had planned to run the study. And those are things that you have to have conversations with the people funding the study and to make modifications. Sometimes the grant reviewer makes modifications. They want you to change your study to the design or approach to something that either fits their personal interest or something that makes sense to them, but it's not going to work in the real world for the community agency. And you have to negotiate that as well. And so flexibility is the theme throughout all of this. Flexibility, you have to be flexible as a researcher, but when your community partner is a true partner, then you can't go with a mindset if you're dictating everything. You really have to adjust on the fly while maintaining fidelity and the quality of the research protocol, the study design, the implementation, the data collection, and data analysis and presentation all through all stages. And so it's bi-directional, it's a mutual thing. listening to and balancing the needs of each party. And I have to say, all of these for 4 points here for the goals, the bifocal vision, they're all backed up by having good partners to work with in the first place. I feel like we have a really good team. I am feel very fortunate to work with the partners that I have. One, to find community partners who are interested in research and understand the value of it and are not trying to take shortcuts, and want to do it right, but who are also just good people and fun people to work with and who are clinicians. It makes the navigating relationship and issues, any conflicts that come up, it just makes it so much easier to deal with than I would imagine other disciplines. So I do appreciate that. But yeah, there are very different things that you have to focus on in terms of, and you won't even know what all of those challenges are until you meet them, because everybody's situations, like any relationship, they're going to be different depending on the players involved. Ken?
And it's creating true partnerships. And then that other part is preventing the alienation of future partners. You don't want to make it so no one wants to play in your sandbox. You want to make it so that you have this thing that can continue to grow and that it can go from one group project to the next one to the next one, and that it's something that develops. Some of the best practices, they're very basic: interpersonal qualities, be a good person, be, truth, trust, responsibility, concern. You have to have that shared mission, vision, and goals. You have to be able to have effective conflict resolution. These are adults. We can't pout and stomp our feet and not take part in the research anymore because our feelings got hurt and it didn't go the way we wanted. We need to be able to communicate that. It's a relationship, even if it has that end goal. Operational processes: who's in charge? Who's directing it? Who's leading the meeting? Who's taking the notes for the meeting? What is the defined roles of it? And then, is your work group diverse? Do you have people from multiple disciplines? Do you have people from different backgrounds, from different experiences to help organize and create, so it's not just a one-sided, well, this is what it should look like? Do you have a mutual exchange of information? Do you share resources? And when we say resources, that's very often money. Is there a process for who's going to be responsible, who's going to take what amount, who's going to organize it, or maybe even act as a fiduciary? So looking at some of these things, they're basic. Be a good person, be organized, and make sure that it's equal and fair for everyone. Not the most challenging things to enter into best practices. Some of the other things to bring to the table as the community, as the research partner, is honest and direct communication about how to split the money. Know your worth. Yes, I'm a clinician. I don't have a PhD, but my time has value. My group has value. Is there a community partner that might be, again, viewed lesser because of who they are, but they're not? They have that value. As the treatment providers, we hold the data. We have some leverage. We have some worth in this, and knowing that. When you bring in research, you hear human subjects training and IRB oversight. Those can be terrifying from a community perspective. We're clinicians. We can tell you all about HIPAA, 42 CFR Part 2, protected health information, and the 14 things I can or cannot tell you. I can't give you their initials. I can't give you their address. I don't know the person. I've never met them. We know this. It's not the 70s where you can do all the research you want and pretend people are in prison. So it's not that. You can understand it. Relying on your university. They have these things called interns. They pay the university so that they can come work for us for free. And man, is it valuable. They send the emails, they make the phone calls, they do some of the groundwork, and they gain valuable experience from that. It's not abusing and using someone. It's this valued and shared experience that comes from it. Then making sure that you can share information easily. Is it Google Drive? Is it SharePoint? Is it Teams? What do we have to make sure that the information can be exchanged? And then make sure that you're willing to share your own resources and networks. Journal publications. If I have to go call Jane at SC4's library or bump into Allison and Mike and go, hey, can your library get me this stuff because it exists only on microfiche or whatever researchers use these days? I need to have that. If you have access to the journal articles, we need to share that. If I have access to the clients or the community, I need to share that. So some of the things that we've done with this Share Collaborative, this group, is some of our work is hoping to bring programs like Project Assert back to the St. Clair County area using a web app known as SciAS by MSU. So taking some programs that may work, evaluating them, and see how we can use innovative technology. Strengthening pregnant and postpartum referral networks. How do we work with the people that are most in need? Is this a network with the health department through SCC Link or through the maternal and infant health program to get some of these pregnant postpartum women the services they need? Then our group is being able to do community presentations. We had Dr. Mallett Reed come in recently. He did a presentation on the lack of racial diversity in substance use and PTSD research. We have access to that population as a treatment provider in Flint or working with partners in Detroit or those. That's where the data lives. The data sits in those EHRs. So it's being able to connect a researcher with a provider who holds the population that they need. And it's easier to find a population who already exists than to go out and recruit one, to go find and hope that the community comes to you. So being able to share where we bring together community and academic partners to see how they can work going forward. Then we have the upcoming Michigan Institute for Clinical and Health Research PACE Training Symposium that we hope to have coming out in 2025 about how to build some of these, how to take that landscape analysis and health equity report card and expand it. How do we help beyond St. Clair County, beyond Port Huron, and other communities as well? And then it's the community benefits. The community gets something that it needs. The community gets a outcome. It gets evidence-based practices. It gets better services. And then you have the academic side that has their own benefits. They get to publish. They get research. The university looks at them and says, that is awesome. You get to maintain your job here with us as a professor or an assistant professor because research is what we need. And then this other side professional part for Emma as a student intern, Emma's able to enter from graduation into a program with real world experience. She's done research. She has her name on those programs. For myself, it moves me out from an office to maybe into this researcher type role. So you get this professional benefit for the people that participate in some of these groups. So it's this full spectrum of how a person can and what benefits can come from this community-based research. So I know we're backing up on time as I rush through the last 3 slides there. We do have some of the sources because academics require you to tell you why you know what you know, or they write and circle your paper with red and say says who, and then some contact information for ourselves. I do believe we can make these slides available. If I get a nod from my peers there that we can probably share these, because I know that's always the question in the chat. I don't know if there were any questions that came through in the chat or anything that we can touch on in the closing minutes here.
I didn't see any questions in the chat.
Okay.
I don't know if any are incoming. Or any you can unmute. Can we unmute folks if they want to ask a question?
They aren't able to unmute. They'd have to use the chat.
Thank you.
And again, we would like to thank you all for inviting us and allowing us this opportunity to share what we've done and more about community-based participatory research with y'all. So thank you.
And thank all of you for presenting today. We appreciate your time and all of your information. I also want to thank everyone that attended the session today. We hope you found the information shared valuable. Today's presentation is one of many webinars scheduled throughout the month of September. To see information and register for any of the remaining sessions, please visit our website at www.sccmh.org. Before we wrap up, we would greatly appreciate your feedback. A survey link will come up on your screen once you exit the webinar. Please take a few minutes to complete it. Your input is crucial in helping us improve future events and better meet your needs. For those of you that are requesting professional credits, please allow 2 to 3 weeks after the summit has concluded and your certificate will be emailed to you. Thanks again for joining us today. We look forward to seeing you next time, and thank you all again.